in some types of autoimmune encephalitis leading to acute symptomatic seizures, there can be a viral trigger. So for example, NMDA receptor encephalitis can follow herpes simplex encephalitis.
Fellow Homo sapiens, welcome to Epilepsy Sparks Insights. Now, there are heaps of autoimmune diseases out there, like, say, Crohn's disease or rheumatoid arthritis, lupus, MS, or psoriasis. Well, joining the delightful pack is Autoimmune-Associated Epilepsy, which is brought about by antibodies and differs from autoimmune encephalitis, all of which shall be explained to us today by star specialist epileptologist Claude Steriade from NYU Langone Health, US. Also, please don't forget to like, comment and subscribe to our channel, because only about 18% of people who regularly listen or watch our episodes are actual subscribers. So it will really help us with the algorithm if you could like, comment and subscribe today, and then we can get the messages about the epilepsies out to more people around the world.
Thanks for having me. So I'm a neurologist. I work at New York University in the Epilepsy Center. And my area of interest is the world where immunology and epilepsy interfaces. So my clinical and research interest is basically people whose seizures may be driven by an autoimmune problem and how we can better identify them and how we can better treat them.
So when I think of autoimmune stuff, I'm thinking of a type of arthritis, or I automatically think of HIV as well, an autoimmune thing. Very different, but so what is an autoimmune epilepsy? How does that work?
So the entity of autoimmunity-associated seizures basically came out of the finding that some people can develop a collection of neurologic symptoms because of inflammation in the brain caused by antibodies that can target various proteins in the brain. And that syndrome is called autoimmune encephalitis, and that's a syndrome that typically presents with rapidly progressive mental status changes, psychiatric changes, cognitive changes, and often seizures too. And in these cases, the seizures don't get better with traditional anti-seizure medication types of treatments, but they do get better when you treat the autoimmune problem with immunotherapy. And so out of this came the idea that there may be people out there who have ongoing chronic seizures that may also be due to these same types of antibodies that target various neuronal proteins, and that some of these patients may not have like the full syndrome of autoimmune encephalitis. They may not be presenting rapidly progressive cognitive changes, etc., but they may be primarily presenting with chronic seizures that's driven by an autoimmune cause. And so that's what I'm more interested in, is the idea that there are some people out there who have epilepsy, who have ongoing chronic seizures that's driven by an autoimmune problem. And in these patients, there's really two things happening. At the very beginning of their disease, there's primarily an autoimmune problem that's driving the seizures. And as the disease goes on, then this autoimmune problem leads to injury to the brain. And then that turns into scar tissue, which then becomes the primary cause that the seizures are going on. And that entity is called autoimmune-associated epilepsy. And the term associated was very carefully chosen to show that it's really not purely an autoimmune problem. It's associated with an autoimmune problem because, like I said, in many of these patients over time, and pretty much in everybody over enough period of time, then it's really a structural problem that sort of sets in that becomes the primary cause of the ongoing seizures.
Basically, if a person has refractory epilepsy, uncontrolled seizures, it can lead to brain damage, structural damage to parts of the brain.
Yeah, so we know that from, epilepsy in other situations that chronic seizures can lead to injury primarily to the hippocampus. But in addition to that, we know that the autoimmune problem in and of itself is actually dangerous for cells. So it's called T cell cytotoxicity. And that's the primary problem that's going on in autoimmunity-associated epilepsy, is their T cells are actually causing neuronal injury. And over enough time, that leads to enough neuronal loss that there's, going to be an ongoing epilepsy from that.
So what causes the autoimmune disorder, though? Is it a genetic thing? Is it an infection? I've read somewhere it could be induced by a cancer.
There's different sort of triggers in different people. And most of the time, we don't really get an answer for that. because that's the primary question that people ask is, well, why did it happen to me? Nobody else in my family has this, etc. So what we know is that people who have autoimmune-associated epilepsy very often have other autoimmune problems in their body. So for example, they may have type 1 diabetes, they may have Hashimoto's thyroiditis. So there probably is some sort of genetic predisposition to autoimmunity, and they can have autoimmunity in their brain just like in the rest of their body. And some types of autoimmune encephalitis leading to acute symptomatic seizures, there can be a viral trigger. So for example, NMDA receptor encephalitis can follow herpes simplex encephalitis. And like you said, in some cases, there can be an underlying cancer. Typically, when there's an underlying cancer triggering an autoimmune problem, it's a very small cancer. We're not talking like metastasized cancer. We're talking a cancer that's typically undiagnosed at the onset of the neurologic symptoms. And it's the investigation of the neurologic symptoms that leads to the discovery of this underlying cancer that's typically very treatable with cancer treatments. But that cancer can sometimes signal to the immune system there's something there that shouldn't be there. It's foreign. The immune system, and trying to fight the cancer, sort of starts creating these antibodies that can then recognize the brain and then create a neurologic syndrome.
How are people diagnosed with this then? Do they come in and like when they're having ongoing seizures, status epilepticus, or does it take a while? What do you need to do to make the diagnosis?
So I feel like there's probably two main situations where people end up being diagnosed with this. So the first clinical situation is going to be when people have acute symptomatic seizures from autoimmune encephalitis. And that's going to be the type of situation where someone comes into the hospital, typically acutely sick with different neurologic symptoms. They may initially have a seizure, but then shortly after they become confused, they're not acting like themselves, etc. And then that's a situation where I think clinicians are pretty good at identifying this. I think we're very attuned to that now. And this diagnostic workup essentially lies around the idea of testing patients for these various antibodies that target neuronal proteins, looking for an underlying trigger like a cancer, getting the basic brain MRI, EEG, et cetera, that can sort of indicate the diagnosis or support it, getting a lumbar puncture to look for any evidence of inflammation. And in that situation, very often a diagnosis comes more quickly, and then immunotherapy is initiated typically early on. The second situation where patients get diagnosed, and that's usually the setting where the diagnosis comes later, is the category of autoimmune-associated epilepsy, where a patient may have chronic ongoing seizures where something is just a little bit off. They don't have any risk factors for epilepsy. It started late in life and became rapidly hard to control with anti-seizure medications. They may have, more severe than expected cognitive issues with their seizures. They may have associated psychiatric symptoms that may be out of proportion to what we're used to seeing with epilepsy. They may have seizures coming from both temporal lobes. They may have certain types of seizures which are associated with an autoimmune cause of seizures, like seizures triggered by music, like we see in GAT65 associated epilepsy, or autonomic seizures where people get goosebumps or palpitations or a rushing sensation over their body, seizures that are very frequent, like happening every day. So there's a lot of different sort of characteristics that may sort of bring a light bulb to their clinician to say, hey, there's something going on here that's not quite right. And then that's going to trigger a similar kind of workup with these antibodies targeting neuronal proteins that you're going to check in blood and spinal fluid. Typically, you do check for an underlying malignancy, get a lumbar puncture for other markers of inflammation, in addition to all of the usual tests that we get in epilepsy. As you can imagine, what I described is that there's a lot of different sort of phenotypic clues, but we're a little bit behind compared to the autoimmune encephalitis situation in terms of having a really solid understanding of like what's good enough or what's enough to trigger a workup. And so a lot of these patients will end up getting worked up a little bit later in the game, because it's a little bit less clear who deserves a workup, who's high enough risk to carry one of these antibodies, and who isn't. The issue that this leads to is that, similarly to the first category of patients that I discussed, time is of the essence. The longer someone has been having these seizures, the longer they've had this autoimmune problem, the more likely it is that there's been some structural injury, and the less likely it is that they'll respond to immunotherapy. And most of the time, when you diagnose someone with autoimmune-associated epilepsy, you don't expect to completely take their seizures away if you treat the autoimmune problem, because most of the time there is some structural injury that's there. And the question is how much inflammation there still is that you can address with immunotherapy.
So what stage of a person's epilepsy or seizure, when the seizures start, do you on average see them? Because I guess ideally you would see them almost straight away, and then maybe you could treat the inflammation, and then maybe, fingers crossed, they could be seizure free. Is it like 2, 5, 10 years or?
I mean, it's so variable. Like I've seen patients like within months of their seizures, and those are patients that do a lot better. And I've also seen patients who have had seizures, for 5, 10 years. And that's when they get diagnosed. And typically they, have a worse outcome. Although you always, give everybody benefit of the doubt and give it a full try to treat an underlying autoimmune problem if you think there's evidence for one. But I would say that it's really variable, and probably the patients that get diagnosed earlier are the ones that have more of those like clinical features that, raise a red flag. We also get patients who will like walk into the office where nobody has suspected an autoimmune problem. That was like my first LGI1 I had in my clinical practice as an attending, was a woman who was referred to like typical Friday afternoon, last patient of the day. And she walked in, she said, well, I just had, one seizure, and she had a convulsion. And that's the story that she came with. She was sent from the ED. There was no one had suspected an autoimmune problem. But when I asked her questions, she actually had these repeated episodes, which she didn't think anything of, where she felt like something bad was going to happen. She would get this like foreboding kind of sensation with palpitations. Her whole face would get flushed. And she was like, actually, this is happening many times a day. And it's started a little bit before the convulsion, and she didn't have any cognitive complaints, but I tested her and she had terrible memory, even though she was this practicing nurse. And, that she turned out to be my first LGI1, and she just walked into clinic one day as a new onset seizure. And, I think it could have been very possible if she had not had somebody who had asked the specific questions about, these types of autonomic seizures and done the cognitive testing, that she could have just been treated as a one-time seizure, and could have gone on for months and months before being diagnosed. So it really gets to asking the specific questions to get to those other features that are going to then raise the red flag that there might be something autoimmune going on.
So would you say autoimmune epilepsies are quite common?
It depends what you mean by common. So there's been a lot of studies looking at this, and the literature is a little bit all over the place. And I think the reason for that is that a lot of the literature was lumping in acute symptomatic seizures from autoimmune encephalitis. So like the patients who were presenting to the inpatient unit with fulminant seizures, but also very confused, et cetera, like not patients with epilepsy showing up to clinic. A lot of the literature was lumping in that with autoimmune-associated epilepsy. So some of the literature had figures like up to a fifth of patients with seizures have an autoimmune cause, which is not true. If that was the case, I would be seeing autoimmune-associated epilepsy in a regular epilepsy clinic all the time. And that's not the truth. So the more rigorous studies have shown that about 1 in 20 people with focal epilepsy of unknown cause, which is a subset of epilepsy as a whole, carry these antibodies. So I wouldn't say that it's common, but I think it's common enough that we need to identify these patients, because they're really unique in the sense that, when you identify an autoimmune cause of seizures, and when you do that early enough, you have such a unique opportunity that we really don't get a lot of in epilepsy in general to treat the underlying cause. And like I said, the success is really variable, and in autoimmune-associated epilepsy, because of the nature of the autoimmune problem, which is T-cell mediated cytotoxicity, there is going to be some structural injury. And generally, I don't tell patients with autoimmune-associated epilepsy, I'm completely going to fix your problem. Your seizures are going to go away. You're not going to need to be on any anti-seizure medications, because that wouldn't be true.
Right.
But you have an opportunity to impact the underlying problem of their disorder. And if you do it early enough, you can do a pretty good job of it, So I think even though it's probably not very, very common, not as common as some of these earlier studies that were lumping in autoimmune encephalitis and acute symptomatic seizures, it happens often enough in clinical practice that it's worth us trying to be mindful of this and trying to become smarter about identifying these patients, hopefully earlier on, so that we can be more effective when we're treating them.
And I'm just thinking of how the impact on people's quality of life later on in life, how that would, rather than get some structural damage because it's taken so long to diagnose or to treat, it would be you're saving taxpayers or healthcare providers a lot of money by getting them in early and to just treat them more effectively.
Right. I mean, that's the other side to this, right? Is thinking about this from a cost effectiveness point of view. And obviously, I don't think you want to be testing everybody with epilepsy for these antineuronal antibodies, not just for cost reasons, but also because you don't want to get results back of low titer antibodies that have uncertain clinical significance that are going to cause clinical confusion, cause stress to patients because they have this finding and nobody knows what it means, et cetera. But you're right that there is a trade-off. If you're limiting a test that does cost some money, you may end up missing a diagnosis, which then down the line is going to cost a lot, in terms of quality of life to the patient, but also financially, to the system. So I think there is something to be said for cost effectiveness of rational screening of populations that are at risk of actually having this problem early in their disease, to improve outcomes and, also probably save money to the system, which I think you're more mindful of. And I'm more mindful of because I trained in a universal healthcare, and that's still in me. But I mean, now I practice in the US. So.
Thank you very much to Claude, who in part 1 of 2 has provided us with such a brilliant insight into what autoimmune-associated epilepsy is, how it differs from autoimmune encephalitis, how crucial an early accurate diagnosis is for seizure prevention and improving quality of life, and indeed for actually preventing sclerosis scar tissue from developing. Make sure that you do join us next week in episode 2 of 2 with Claude, where we talk about the common symptoms of autoimmune-associated epilepsy beyond seizures. Do check out more about Claude and her work on the website torierobinson.com, where you can also access the podcast video and transcription of this episode. And if you haven't already, don't forget to like, comment and subscribe to the channel. Share this episode with your friends, colleagues, family members, whoever, and see you next week.